Topic is Orbital Ordeal Navigating the Management of Cellulitis, and the speaker is Dr. Soumya Narayanan. She is the consultant oculoplastic surgeon and visiting consultant in multiple hospitals in Calicut.
Good afternoon all. So you have heard about few of the ocular emergencies. So what will be your diagnosis when you see a patient with this picture? The patient has severe lid edema, erythema, proptosis, extraocular movements restriction, diplopia, pupillary abnormalities. And when we check, patient can have a increased IOP, raised retrobulbar resistance. So what will be your diagnosis? First diagnosis, orbital cellulitis. So by definition, infection of the soft tissues posterior to the orbital septum is termed as orbital cellulitis. And Chandler's classified the cellulitis of eye into 5 groups. The group 1 including the inflammation only to the anterior to the septum, and group 2 is the orbital cellulitis. Group 3 onwards is the complications. Group 3 is the subperiosteal abscess. Group 4 is orbital abscess, and group 5 when it is going beyond the orbit, that is the cavernous sinus thrombosis. So by etiology, the most common cause is the spread from the periorbital structures, mainly the paranasal sinus. Then it can be due to exogenous causes like trauma, foreign body, and endogenously can be due to bacteremia with septic embolization. Intraorbital spread can also occur in case of endophthalmitis and dacroadenitis when it is spreading beyond the posteriorly. So in children less than 9 years of old, aerobic and single organism will be the cause. In children more than 9 years of old and adult, polymicrobial, anaerobic and aerobic bacteria, fungal or mycobacterium will be the cause. So most common cause of orbital cellulitis is Staphylococcus aureus and Streptococcus species. The fungal pathogens can also be there. You can see a aseptate fungus here. That is the mucor, and this is an septate fungus, Aspergillus. Both these fungal pathogens will affect the immunocompromised patients, and we should check for the skin, mouth and nose for any black scar. So for evaluation, you should see for the signs like redness, edema, ptosis. The skin can feel warm to touch. Pain can be elicited with either touch or eye movements. Examination of the nose, mouth and skin lesions will suggestive of fungus infections, and the systemic status of the patient should be checked. So when we evaluate, we should check for vision, any decrease in vision, color vision. The measurement of the proptosis is very important for monitoring the patient. Should check for pupillary abnormalities, ocular motility, and direction of the displacement of the globe is very important, because if there is a subperiosteal abscess, it will push the globe in the opposite direction. And if the patient have a bilateral involvement, always think maybe the infection will be spreading to the cavernous sinus and through retrograde to the other eye. And IOP should be monitored. Fundus examination for optic neuritis and any retinal venous occlusion should be ruled out. So first we have to differentiate between preseptal and orbital cellulitis. So when the infection spread to the orbitals beyond the orbital septum, it can produce proptosis. And when it affects the extraocular muscles, we can have pain with extraocular movement and ophthalmoplegia. And when it affects the optic nerve, vision impairment and pupillary abnormalities will be there. So when in doubt, we should always order for imaging. And in first case, you can see the hyperdense areas are more anterior to the orbital septum, and there is also a ethmoidal sinusitis. In the second picture, you can see most of the hyperdense areas are in the posterior to the septum, and the sinusitis is also present there. So imaging, CT is the imaging of choice. In MRI, it will be recommended in children to avoid radiation. And also when we are suspecting cavernous sinus thrombosis or any intracranial complications. Imaging is warranted in all cases of childhood orbital cellulitis, poor response to intravenous antibiotics, and confirm the presence of any complications. So in the CT, you can see the patient have in the right side proptosis. There is increased attenuation of the periorbital fat and also infiltration of the postseptal fat. You can see hyperdense areas here. And there is a crescent-shaped soft tissue mass near to the lamina papyracea in the medial part of the orbit, indicative of a subperiosteal abscess. And opacification of the ethmoidal sinus is also present suggestive of the cause. So this is a contrast enhanced fat suppressed T1 weighted MR image. You can see right proptosis, heterogeneous enhancement of the orbital fat here, and ethmoidal sinusitis. So complications also can be picked by the imaging. So here there is a meningeal enhancement suggestive of meningitis. There is swollen and non-enhancing cavernous sinus, and also you can see a narrowed internal carotid artery here. So differential diagnosis, the first one is the orbital inflammation. It can be also mimic as neoplasia, trauma. All these causes can mimic orbital cellulitis, systemic disease, thyroid eye disease, and caroticocavernous fistula. So always we will be confused whether it is a orbital cellulitis or it is a orbital inflammation. So orbital inflammation is a diagnosis of exclusion, and the features suggesting of orbital cellulitis are a history of sinusitis, trauma, or recent history. And the fever will not be present in orbital inflammation. In the blood workup, you can, if you get a neutrophil predominant leukocytosis, that is more favoring of orbital cellulitis. On imaging, both can appear as a diffuse inflammatory process, but sinus pathologists will direct more towards orbital cellulitis. And in case of MRI diffusion weighted image, we can see orbital cellulitis will restrict the diffusion less than the orbital inflammation, because orbital inflammation is more cellular and orbital cellulitis is more of edema. So for management, admission to the hospital is a must for IV antibiotics and for monitoring. Initiation of broad spectrum IV antibiotics that addresses the most common pathogens, and we will modify the antibiotics according to the blood culture and nasal throat swabs. So third generation cephalosporins are our first choice. If it is not controlling, we can also add a penicillinase resistant penicillin. If we are suspecting anaerobic organism, if you should add a clindamycin or metronidazole, there will be gas in the image in the CT. In MRSA infection, we should start vancomycin, and if there is improvement in 48 hours, we can shift to oral drugs. So treatment of sinusitis along with this treatment is very important. We can take an ENT help. Either medical or surgical drainage is important. So when we are admitting the patient, we should monitor the vision, any deterioration, any increase in proptosis or chemosis, pupillary involvement, worsening of symptoms. And if the patient is having severe headache and altered sensorium, always think of intracranial complications, and systemic compromise should be seen. So corticosteroids in the management of orbital cellulitis are always a debate, but there are many studies suggesting the benefit of corticosteroids, like reduction in duration of the antibiotics, length of hospitalization, and incidence of abscess drainage. There is less pain, periorbital edema, fever, and chemosis if you are treating with corticosteroids. And there are studies showing at 12 weeks of follow-up, less residual proptosis and restriction in the extraocular muscles, and no adverse effects. But with all these things, when you are starting corticosteroids, we should also think of it can mask the clinical course and allowing the infection to progress by immunosuppression. So in case of subperiosteal abscess, we can observe with intravenous antibiotics if the child is under the age of 9 years and there is no intracranial or frontal sinus or dental abscess, and there is no vision loss. And in case of orbital abscess, we should always drain. And in case of subperiosteal abscess, if there is intracranial extension, optic nerve compromise, clinical deterioration with antibiotics, and suspicion of an anaerobic infection and recurrence, we should always drain. And what the pus, we should send for culture and susceptibility testing to tailor the therapy. The dangerous complication is the cavernous sinus thrombosis. Even though incidence is very less, the mortality is high. So it's related to the thrombophlebitis in the ophthalmic vein, and sometimes it spread through the valvulus upper and lower ophthalmic vein, and also sometimes due to systemic infection leading to a procoagulant state. So we should suspect it when there are some more symptoms like headache and systemic toxicity than orbital signs. Early diagnostic imaging with contrast will help us, and multidisciplinary approach with a neurologist and ENT should be done. And the treatment entails broad spectrum antibiotics, anticoagulation, surgical drainage, and sinus surgery. So early diagnosis and treatment is a must in case of orbital cellulitis, and close monitoring and detection of complication also very important. Thank you.
Thank you, Dr. Soumya, for that informative and elaborative discussion.